Okay, good afternoon. My name is Janice Fagen, and I'm really excited to be moderating this panel called Putting a Business Model Around the Social Determinants of Health. And I'm going to quickly review the agenda, and then I will introduce our esteemed panel for today. So you're going to meet our panel, and they're going to do an overview of their respective health systems. And then we're going to get into what exactly does it mean when we say putting a business model around social determinants of health. So without further ado, I'd like to introduce our first speaker, who is Heather Beal with the WISE Health System. I just want to make sure you all can hear me. If someone can just put it in the chat that you can hear me and that the audio is good, I would appreciate that. Heather manages the WISE Health System's participation in government programs. We heard a lot about this earlier today during the conference with respect to the Texas 1115 waiver, affectionately known as DSRIP. She's based in Decatur, Texas, which is a rural county northwest of Fort Worth. But it's one of those rural counties that I think is quickly becoming more suburban, so they're going through some changes. She also evaluates new grant opportunities for the health system and specifically around investment in social determinants of health. So this is really in her wheelhouse. Currently, she works with 60 community partners throughout the county, and the work that they do helps to reveal the needs that are documented in their community health needs assessment. She told me she's really passionate about food insecurity, and she received her education from two very fine Texas universities, Texas Tech and Trinity University. Our second speaker is Dr. Teresa Brown, who is the Regional Chief Medical Officer and Medical Director at CareMore Aspire, based in Fort Worth. So both of our speakers today are from that particular part of the Dallas-Fort Worth area. Through partnerships with employed primary care providers and health plans, CareMore is offering data-driven holistic care for high-risk members, and they do that through value-based contracts, which is very interesting how combining social determinants of health in the context of value-based contracts. Through their Aspire division, CareMore also offers specialty palliative care. And so I have two very passionate speakers today. Dr. Brown is passionate about food and housing insecurity, and she is also still providing direct care to her patients in addition to her administrative duties at CareMore Aspire. And she also hails from two very fine Texas institutions, the University of North Texas Health Science Center, where she received her internal medicine training, and the University of Texas Health Science Center in San Antonio. And lastly, I'll just quickly introduce myself. I'm Janice Fagen, Senior Strategic Advisor at Sellers Dorsey. I really come from a different background than our other two speakers in that I've spent almost all of my career working for managed care companies. And most of that time was in Texas. My most recent role was at Blue Cross Blue Shield of Texas, where I was responsible for the Medicaid program. Unlike Heather and Dr. Brown, I did not go to Texas schools. I was educated in California, but all three of my children went to UT. So we've got all of the Texas universities well covered here. Okay, now we're going to get into the specific health systems that we have with us today. So Heather, if you would kick it off and talk to us about the WISE Health System overview.
Absolutely. So I work for WISE Health System, and as Janice said, that is northwest of Fort Worth. So if you know where Denton is, if you keep going a little more west, you're there. And as she said, she's very accurate. We are quickly becoming what we're affectionately calling suburban. We're getting there quickly. The county is growing at a very rapid pace. Wise Health System is the largest employer in Wise County. I think we're at this point getting close to 2,000 different employees. We are a 3-hospital system, so our main hospital, acute care, many of our services is within that Decatur area, but we also have 2 surgical hospitals, one in North Tarrant County and kind of the Alliance corridor kind of area, and also in Argyle, which is in Denton County. We are a 501c3 not-for-profit organization, and in conjunction with the hospital, we also have the Wise Health Clinics, which provide over, I think there are 18 of them, if not more now. They provide primary and specialty care throughout Decatur, Wise County, outside of Wise County sometimes also. And so something interesting about Wise Health System is we have over 75 access points throughout North Texas. So we have many partner organizations. So you might see us at an imaging center or somewhere like that in Fort Worth. Our My Bariatrics program is in Waco and several other places. So we have a pretty far reach for being so rural and a little bit tinier, I would say. So I wanted to put this up there. This is our mission, vision, and our values. And I won't read it to you. I like that we can use the word WISE, and acronyms just flow from that. But something that's really important to me and very applicable to this conversation is in our mission and in our core values also, but to provide compassionate and innovative care to our community. And that's where it really hits home for me. We are all about our community. If you've ever lived in, been in, spent time in a rural community, they come together. It is a very close-knit family. And that is no different for Decatur and Wise Health System. And so we are very involved in, very appreciative of, and very interactive with our community. And we find that to be very important. But we also know that it has to start at this level. Our community involvement has to be at our mission, our vision, and part of our core values is being involved in that community. So that's why I put this in there. So that's a little bit about Wise Health System, just as a general overview. But I also wanted to give a little bit of information about social determinants of health. Some people call it social drivers of health, and kind of how we look at it and kind of some of the information that we found. About 80% of someone's health has absolutely nothing to do with the healthcare that they receive. So if you look at this chart, it's about 40% socioeconomic factors. So what is your education level? Different things like that. Do you have employment? Is it enough to support your family? Do you have those family and social support services that you need? Healthy behaviors, which is something that we look at a lot, are there parks for you to go walk at? Do you feel safe at those parks? That would also be part of your physical environment. Is your water clean? Is there lights out there in those areas for you to feel safe? Different things like that that we don't think about as part of our overall health. But they really do factor into that overall health. So that clinical care, that healthcare is 20% of our health, what factors into it. Now, having access to that care is absolutely essential, but it's these other factors that really are important to being able to have a completely well-rounded, healthy lifestyle and healthy living. So something that's very important to us and something that we do through Healthy Wise County, which is kind of our outreach into the community, I guess you could say, is having very involved community partners, not-for-profits, any local government entities, other local healthcare, for instance, home health, things like that. We don't have a public health department in Wise County, so the hospital acts as that entity also. Other businesses, education, those sort of things. So that's who we partner with in Healthy Wise County to help address and drive some of these social determinants of health. All right. So that was just kind of an overview of what social determinants or drivers of health is. So my role is DSRIP and community health manager. So I was going to address them kind of a little bit separately because they both intersect with these social determinants of health, but in very almost kind of different ways, but they overlap in some ways also. So I'll start with the community health manager. So I work with our organization called Healthy Wise County. We start with our community health needs assessment every 3 years. We created, we have 3 committees: healthy living, healthy behaviors, and mental health and substance abuse, to address the needs that were identified in our community health needs assessment. There were 11 of them because we couldn't just have 10. There was one more lingering out there that I was like, yeah, we really need to talk about that. And I won't tell you all 11, but some ones that aren't directly related to access to healthcare: food insecurity, transportation, physical inactivity, things like that have nothing directly to do with the care that you receive, but have everything to do with making sure that you're healthy. So each of those committees is assigned a group of the needs that are identified, and they work as those community partners to address those needs. And that's one of the amazing things about working in a rural community. They band together. Although it's led by the hospital, I have to say we have some of the best community partners out there. They are amazing. They're always willing to help. They have great ideas. And sometimes they have the resources that we don't. And they know the things that we don't. And sometimes we have things that come out of our community health needs assessment that for the hospital or the clinics we know are within our scope that we need to address, but we take those things and we partner them with the community. For instance, Wise County has a Hispanic population of about 20%. Very few of our physicians spoke Spanish. So we were like, okay, this is a need we need to address. So we hired a physician specifically to address this need. He speaks Spanish, and he had a focus on diabetes. He's an internal medicine doctor, but focused on diabetes. So when we got him on board, we started integrating him as best we could into the Hispanic community, and we utilize our resources. In one of the local health departments, they have a regular meeting with the leaders of that community called Unidos, and that is how we're getting that care to that community and meeting their needs in that way. And we found this out through our community health needs assessment and seeing the communities that what really needed to be there. So we take these needs that we have and we address them in multiple different ways. One way I will talk about is food insecurity. That's something that's huge for us. We started out with just like a food pantry flyer. Hey, here's all of the food pantries in Wise County. Here's when they're happening. Here's the mobile ones. You would be shocked and amazed for such a suburban community to have that many food pantries. I think you could literally go every day and visit a food pantry, but how are we addressing that need, and how are we incorporating other needs of the community and those populations into that food pantry? So where is that partnership happening?
So Heather, we're going to get more into that in a bit.
Okay.
It looks like we have a poll here. Will SDOH receive the same amount of attention after COVID subsidies? So we want to make sure that everyone answers that. I'm just going to pivot now to have Dr. Brown talk about CareMore and Aspire. So I'm going to bring up Dr. Brown's slides. And Dr. Brown, take it away.
Thank you so much. Heather, really enjoyed listening to the work you're doing. I was a hospitalist for 5 years at Harris Methodist downtown, so I remember greatly the transfers to WISE, and know that those patients definitely need support in their community. So happy to hear about the great support you're giving them. I'm going to take just a couple of minutes and go through what CareMore and Inspire Health is. So we have CareMore has been around for about over 15 years. Based out of Southern California, started as a IPA that grew into a Medicare Advantage plan in California and expanded east. About 6 years ago, they started working with MCOs. Hence, we had about 5 markets that opened up and began to work with our AmeriGroup partners. We are now a subsidiary of Anthem. And so as our parent company has identified areas where they needed support from provider groups, we have came in and helped support those communities. So in terms of North Texas, we have the CareMore Health Center that's based in Fort Worth. It is a mostly Medicaid population, and through our payer AmeriGroup. All of our contracts on the CareMore side are value-based contracts, meaning that we don't do fee-for-service. And so we're set up just a little bit different in terms of funding than your average PCP group. And our focus is really based on delivering high quality care and giving value back to our patients as well as our payer. About 3 years ago, CareMore bought Aspire Health. Aspire Health is the largest home-based palliative care company. It is also a national company that started out in Nashville, Tennessee. And they are also located in Texas. Dallas and Fort Worth are part of their regions as well, specifically North Texas, but they also have areas in Houston, El Paso, Rio Grande Valley, and Austin, San Antonio. So, if you can go to the next slide, I can remember what I'm supposed to say. So I'm just kidding. So we have really, it's really been a evolution for CareMore. So starting in Medicare Advantage, when we started to open up Medicaid markets, it was extremely eye-opening, for our company. The first couple of markets in Tennessee and Iowa were really opened along the clinical model that the Medicare Advantage markets had opened, in the West Coast. And we very quickly determined that the needs of our patients were not met with a model that was based along a Medicare Advantage population. So a couple of those highlighted areas that we found very quickly that we needed to focus on were behavioral health, drug and substance abuse, which many times is intertwined with behavioral health, and then also social issues, which we didn't have a name for them at that time, but now we do, social drivers of health. And we very quickly realized that all 3 of those are really driving our patients' health, and therefore, if we did not address those 3 areas, that we were not going to be able to really get our patients where they needed to be and add the amount of value that we needed to add. So Texas was one of our first markets that we had kind of learned our lessons from our previous markets. And we were very fortunate to be able to open roughly 3 years ago and start off in a different space, I think, than our previous Medicaid markets. With the acknowledgement of what was really needed to make this successful, we were given free range to really try to implement a clinical model that really made sense for our population. I was a part of that original team. That's when I joined CareMore, was roughly 3 years ago, and helped build the Fort Worth market in the Fort Worth clinic. So through a really amazing collaboration with our community partners, just like Heather pointed out, that's key to the success of taking care of our patients. We were able to set up the CareMore Hope Food Pantry. As we started to screen our patients for social determinants of health, what we realized is food insecurity was really driving a lot of our utilization into the ER. Second was housing insecurity, and third was transportation. Now, that was, our population in Fort Worth. Now, depending on where you are in the country, we have noticed that changes. I just want to make a quick caveat back to Heather's point about, local healthcare. I can't agree with you more. If you look at our Nevada market, which we did a social determinants of health pilot there for our Medicare Advantage patients, their SDOH findings was actually high in the finance area. So more financial instability and insecurity, paying for their drugs, the medications, and second after that was actually transportation and the transportation benefits that they had through their Medicare Advantage plan. If you go to our Virginia market, which is a Medicare Advantage plan or program, clinical model in Richmond, their SDOH actually matches a Medicaid population. So their SDOH is more food, housing, and transportation, similar to Texas, even though their population is Medicare Advantage. So I think that was it was a very interesting learning curve, that we had when we started to review our SDOH screenings. And so out of that, back to Texas, out of that came the idea to work with the food bank and team up with some different areas that we could support the food insecurity. And when I'm done going through this area, I will tell you quickly about a really amazing story specifically out of North Texas. So we initially started with emergency food distributions. We worked with the Tarrant Area Food Bank, who's been an amazing partner. They have also partnered with our payer and to work and look at areas that the payer could support the food bank as well. And we were able to first start with those emergency food distributions. So we had over 400 distributions of food to patients from our Hope Pantry when we first opened. So that was our first step. That was in June 2019 to June 2020. So even through the pandemic, we were distributing emergency food packets. So we would, once patients learned that we had food, we would have people call or people walk in. We were located right off Rosedale. And so we would have people walk over and say, I don't have food. I ran out, last night. And, they're one of our patients, and we would give them an emergency food packet along with our community health worker would become involved and identify a longitudinal solution for them, which many times took months. So we supported them, and as did the food bank in the short term in getting them to a longer food solution. We also partnered with the Tarrant Area Food Bank to do a mobile food pantry. So we had them come over to our clinic, park their 18-wheeler, and our payer AmeriGroup, along with the food bank and along with us, socialized and marketed the event. As patients came through, and it was open to any AmeriGroup patient, it wasn't just limited to our panel, but as our panel came through, we closed gaps. So we would, check their blood pressure, similar to what Heather was saying. It's a really nice engagement measure to get people engaged in their health. So we would check their blood pressure, make sure they had a follow-up appointment, checking their weight. We have point of care testing for A1C, lipids, and we're able to do some education. We had our CHWs on site to help those patients who were receiving the distribution of food. So, and then the last area of partnership that I think was the most spectacular one was our PAR X program. So we were funded through our payer to actually set up a legitimate food pantry. If you see in that first picture, that really beautiful refrigerator in the back was funded by our payer. And we were able to set up a food pantry in our clinic, working through legal channels and making sure that we got all the regulatory areas checked off in order to do that. As part of that, the Tarrant Area Food Bank, we started having classes with our patients. So you can see the middle picture is our first class. And we had 2 moderators from the food bank who would talk through food and how it can be used as health. They would bring healthy, not obviously healthy, but also fresh food. So that picture, the second picture is corn, spinach. We had a nice selection that they could shop. And you could see the recipe cards that were right next to it that didn't involve necessarily a fully functioning kitchen. So that, patients could utilize the fresh food, in an efficient way. So they could follow through with the recipes that we were going through. And the recipes were simple as well. So we had a group of patients that we carried through the first round of the PAR RX, very small, the ones that kind of kept, kept attending. I think we started with 35 attendees, but the ones that really stuck with it, that was about 12 patients. And so we saw an improved engagement for those patients. So an increase of 14 to 19% kept rate from those patients. We had an average of 6.5 weight loss, a reduced BMI by about 1.12, improved PHQ-9 scores. They reduced by about 3. PHQ-9 is your depression screening, just to get some understanding of what that is. And of course, BMI is your weight and your height. And then we had to reduce emissions by 0.36, and we measure something called a metric called ADK, which is your emissions per 1,000. And so from this population in particular, we had about a 36% reduction. I will say quickly, a side effect from a positive side effect from that class was we had Bible studies form out of that class. We had people realize that they lived around the corner from each other and held each other accountable. It was a really fantastic, it was just a really fantastic experience, not only for the patients, but for the staff, for us. We would sit in because it was just fun to listen to them talk. And it just created a sense of community that I think was really important. I will put a little caveat. It did get paused for COVID for a period of time through the great partnership we had with the food bank, which I can't say enough, praises about our food bank here. We pivoted to virtual. We had our community health workers go out and assess the virtual capabilities for our patients who wanted to participate. We gave them the option of coming in and participating on an iPad in our clinic and setting up transportation if they didn't have the option to use, you know, their state flip phones where they couldn't participate. And then our community health workers delivered the fresh foods to them the day before the class so that they could participate along virtually. So definitely a nice pivot. We're still waiting for data to come back from that. That just started over the summer again. So, and then lastly, I will just say this is a little bit of the overview of where we serve. You know, our focus is on medically complex patients. That's, you know, where I think we do our best work. We serve over 180,000 patients across the country, and we focus on complex care, palliative care. We do have full population health and several of our markets, and then senior living care, which some of you may recognize the product called iSNP or IESNP, which is a Medicare Advantage product.
Great. Thank you
All
so
right.
much. So we're going to pivot now to some questions. We actually have questions that I came up with, but we have some questions in the chat, and we also have another poll. So let's answer the poll first. With the knowledge of the importance of social determinants on health outcomes, what should be the next step to incorporate them into our healthcare system? There's a question in the chat that directly related to some things that you talked about, Dr. Brown. So I'm going to go to that one first. It says, when you did your food event where you brought in the big truck and then you were closing, you mentioned closing gaps. Were people willing to engage in that sort of more medical activity when, you know, the main reason they were there was to pick up food? If you could just talk briefly about that, and then we'll go to our question number one.
Yeah, in fact, I would say, quite frankly, the food distribution broke the ice. You know, I mean, it really breaks down because I think what they saw is we were getting to the core of the need for them to survive. And once you eliminate the survival instinct, right, that we don't have food or we don't have housing, I think people can finally focus on their health. And so, and I will say, quite frankly, we have an extremely talented group of community health workers. We have 5 of them. They have worked across the continuum with public health, you know, different community organizations. And I always liken them to paramedics who are seen as civil servants to a certain extent. They're not exactly seen as clinicians and as healthcare. And there is just you know, a really nice engagement that seems to happen as them being the front or kind of the first face they see. And so to me, we really didn't have an issue with people engaging. You know, our clinicians were going around and talking to people. I mean, it really became a more community event and not a health event. Their health was just kind of a part of the event, right? So
yeah, I would say in my experience, it's a very effective way of closing gaps. Occasionally you may have, we've done immunization events that were tied to food events, and occasionally you'll have someone say, you know, I really don't want to get a shot today because I won't feel well and I have to go to work or something like that. But other than that, we found it to be really effective. Heather, I think you had a similar story about how you had paired a food event with other clinical activities like taking blood pressures. Do you want to take a minute just to share how WISE actually did a very similar kind of program to what Dr. Brown's been talking about?
Yes, and we call them mobile health fairs. We typically in Wise County would have a huge health fair every year. Due to COVID, can't do that. So we kind of pivoted and changed direction. And so we go out to each of the food pantries and we provide a service, some kind of health service. So we'll do blood pressure screenings, glucose screenings, that sort of thing. And then we'll also ask that food pantry, is there another service? Is there another issue you're seeing within those that come to the food pantry? So we will pull from our group of community partners to address whatever that need is. We found that there's three things that have to be there: the screening, the additional service, but also something we found to really get people out and willing to do those screenings is we partnered with Texas A&M AgriLife Extension Office. They're Better Living for Healthy Texans, and she brought out like a healthy muffin or something like that that she had made. She had the recipe card, really simple, those sort of things. And in order to get your muffin, you gotta, you got a blood pressure screening, or you'll get a glucose, whatever it is. That way, they're like, oh, well, I can make this. This is simple, that sort of thing. So that's one way
that's a great example. So it's a little bit of bribery, but it's healthy bribery. So that's a good thing. So, the title of this conversation was putting a business model around social determinants of health. And when they first told me that, my mind immediately went to typical managed care executive. What's the ROI on solving for social determinants of health? Put it in terms of dollars and cents. And I do want you to talk about that from a financial perspective. But my mind also went to, what do we do in business? It is about, sustainability, right? It's figuring out how to make things be sustainable. Money is one part of that, but another part of it is data collection, monitoring, feedback loops, feedback systems. We've heard a lot about that. It's great to tell people to go to a food pantry, but how do you know they went? What proof, what documentation do you have? So I'm kind of weaving a lot into this, but I guess starting with you, Dr. Brown, can you talk about why did CareMore make this investment, and how can you demonstrate that your investment paid off, not just financially, and you did allude to this already, but in improving health outcomes?
Yeah, so I think for us, we have a really nice view that's a little bit more holistic, potentially. We have access to acute utilization for our population as a result of our, being assigned a population from AmeriGroup. So we are measured on our EDK, ADK, and for those who, aren't as familiar with that, those are your admissions in the ER and your admissions to inpatient hospital per 1,000. We have our MLR that we're held to, MLR targets that we're held to, in some of our contracts, as well as our closing of gaps in some of our contracts.
Could you just explain what MLR is for people who may not know?
Oh, sure. Sure. It's a medical loss ratio. It's basically the expense versus savings for a population that you're managing. It's so funny because every day my meetings are full of these terms, and so you just kind of spout them off as if everyone knows what they are. So thank you for stopping me. But if you look at it from a plan's perspective, what we did is we screened for SDOH, and our screening actually translates it into a code into the assessment and plan of our clinicians. So the code actually gets transmitted over to our payer. And so they're actually able to monitor the screening that's being done, the identification of the gap. And then, we can monitor those with a higher SDOH and kind of their utilization. We haven't gotten that quite sophisticated yet with our data. We're working on it. But I think what we present is we present the type of SDOH, how we've intervened on it, and then, the utilization that that patient has had. And if you're able to connect a couple of things, so that's why I brought up gaps earlier, for MCOs and Medicare Advantage, closure of gaps has financial weight for them, right? So in engagement, historically for Medicaid patients, it can be low. So engagement is always a discussion when you're talking about that population and how are you going to get your engagement rates higher. So once you get in front of them, you actually can help them, right? So I think it's a stickiness for engagement, addressing the SDOH, because like I said earlier, for the patient, their buy-in is that you're identifying that I'm trying to survive, and you're going to help me get out of the survival mode and pivot to my health, right? And that is key, that the patient understands that you see that. So the engagement increases as a result of addressing the SDOH. The methods that Heather, talked about earlier, and then I talked about, earlier, you close gaps. And then you basically align SDOH, especially in this population, with a decrease in utilization. And if you don't mind, if you'll give me 2 minutes, I will tell you a really fantastic story.
Please do.
About
and
how
then,
this,
yeah,
yes.
I'm just going to say, let's hear your story, and then we're going to pivot. We have a great question in the chat, a couple of them. Then I'm going to pivot to Heather to answer the one that's specific to her. So go ahead, Dr. Brown.
My story is, we had a patient who was they were going to the ER every single day, sometimes twice a day. And I'm sure Heather knows these patients as well, maybe. And so, and we could not get her into the clinic, every time. She didn't have a working phone. Every time that she would hit the ER, we actually had a case manager at that time in the ER, and they would grab her and they would say, what's going on? Why are you coming to the hospital? And all of those things. And she was fairly elusive, didn't really want to participate, And so me and one of my social workers decided that we were going to try to find her at home. She had missed multiple appointments, mostly because she was in the ER when the appointment happened. So we went to her home and found her. We happened to catch her. And what we found, and this will get to one of your questions down the line of meeting patients where they're at. When we evaluated her home, she had a kitchen that wasn't working, it was half burned down. And she had partial paralysis from a previous stroke. She was an active drug user, so she had kind of burned her bridges with her family, so she didn't have a caregiver, essentially. And her house was just, it was in very poor condition. It should have been probably condemned, but she owned it. The only thing she owned. It was the only thing she owned, and she was not going to give it up, and she was not going to get a facility. So anyway, it took us 6 months. Another point I want to bring up is there's a longitudinal key to this success. And so episodic is helpful, but it won't solve it longitudinally. So that was key. It took us 6 months. It took us working with the ER case managers. It took us working with our amazing MedStar paramedics here in Fort Worth. I can't give them enough props for being amazing partners with us. And we essentially identified, she had unstable housing, she had unstable, unstable food, access to food, and she was lonely. She utilized the ER for food, and she utilized the ER for comfort, for loneliness. She had no one. So my social work, who's amazing, as all social workers are, worked, and we were able to put in, get her more stable food. The housing was always a tricky situation. She did not want to leave, and we tried everything. But what did happen is we were able to mend some family abrasion and had someone come in who started to help work on her house. And we went from a utilization of 1 to 2 times a day to once every 3 months.
Great. That's a great
And she
story.
still continued her drug use. We tried and tried. She still continued it. But we met the food and some of the loneliness and housing insecurity, because that's really what was driving her utilization.
Thank you, Dr. Brown. So Heather, the question for you is, when Wise Health provides clients with a list of food pantries, how does Wise help those pantries ensure that they have enough food? So I think the question, and it's a really good one, is as we are all getting more into recognizing the importance of social determinants of health, what are we doing to help ensure that the community-based organizations are adequately resourced? So I don't know, Heather, if you can speak to that for your particular area.
So I know, just working with many of the food pantries recently, they have kind of a ratio about how much they should expect and how many they should expect. Sometimes it fluctuates. I was recently at a food pantry that, the week before they had 23 families. This week they had 50. And they had a lot of new families come in. So they never know exactly how many it's going to be, but they have a pretty good baseline because most of our food pantries are fairly well established. And have been within the community for long periods of time. I would say during COVID, the need expanded quite a bit. So taking those on, they made sure that they addressed those needs and had that food available to them. But they kind of have an idea and a ratio based on who has shown up in the past and things like that, how many families.
Yeah, and I would add to that many managed care organizations are looking at which food pantries their members tend to use the most and are entering into philanthropic relationships with those pantries to make sure that there's enough food for their members first and foremost, but then for the community at large. And, I think Dr. Brown, you spoke to that you would make these events available not just to your panel of patients, but to the broader AmeriGroup organization. And then even beyond that, I am confident that AmeriGroup and all the other MCOs are engaging in donations and various kinds of events. This is a big concern, and it was a great question that you asked, is we have to be cognizant of the fact that these community-based organizations have limits. They have staffing issues just like everyone else. And so I think I want to pivot to Logan. Logan had a question that I think I'm going to take a stab at it. It says, what do you think HHSC can learn from initiatives like CareMore's Hope Food Pantry in order to improve its efforts to address SDOH? I think that HHSC is quite aware that the best way to solve for these problems rather, is at the most intimate level, if you will. So what CareMore is doing, where their physicians are actually writing prescriptions for healthy food and writing prescriptions to go to classes, is a great example of, kind of pushing it down. Where Heather talks about what they're doing in the community, I believe HHSC expects that we are all working together collaboratively. And both of these speakers gave just beautiful examples of provider payer partnerships, community payer partnerships, community, I think Heather said, how the community comes together. So I think there is no one right way of doing this. I've seen similar kinds of initiatives. I think the local area really determines that. Dr. Brown talked about even the demographic of the member. There's a difference between how members on Medicare Advantage, what rises to the top for them versus Medicaid, and then it differs again regionally. So there's just one last thing. We actually had 3 questions really to cover us in the event that the audience didn't have any questions. So we don't need to go through all of them. I would just like Heather maybe to speak briefly about how does WISE finance your efforts? Like, what is it that you are doing in terms of whether it's funding your programs, like your food insecurity programs? How do you sort of rationalize and put the business case on it for the WISE system?
Absolutely. So, as I talked about earlier at the beginning, that's part of our mission and our vision, our core values. So, our health system is willing to put at least a little bit of budget around that. We also try to supplement as much as possible, depending on the program, with grant funding. So, going out looking for those grants, making sure we meet the requirements, things like that. Also, I would say, in answer to that question, HHSC is learning. I work heavily with the DSRIP program, and that is quickly transferring over into, the directed payment programs. And one of those is within the clinics. One of those requirements is a food insecurity
Oh,
question.
that's great. Yay. That's
Yes.
wonderful.
So that's something that we know for sure we're going to ask in our clinics, and we need to be able to address that need. So what Teresa was talking about is like our gold standard of being able to have like the refrigerator and all of that. But right now we're just working on with our clinics, hey, food pantry flyer, but also sending them home with a box of, non-perishable food items that they can utilize right then and there. So that's kind of something that we're working on in conjunction with the directed payment programs, to make sure that we not only ask the questions, but are able to address the need.
That's fantastic. Well, maybe the two of you can collaborate. It sounds like maybe for the DSRIP, the future of DSRIP, you might be able to get some great ideas from Dr. Brown. I want to thank you both so much for being here today and sharing the great work that you're doing. It's been a pleasure to get to know the two of you. We are like a minute over. In the next session, I think we'll start in about 8 minutes. Thank you all. Enjoy the rest of the conference. Bye-bye.
Thank y'all.